Saturday. How many people have exams next week? I heard a fair few of you do, so good on you for that. My name's Eric Christensen. If you guys don't know, I'm the owner of this clinic, and I've seen a fair few of you in here as students, so thank you for coming back. Glad we didn't scare you away too far. And this is obviously Lisa. But before we get started, can everybody stand up for me? Can you stand on one leg? Okay. Can you put your foot back down and do a squat for me? And now I want you to imagine if you couldn't do that.
I'm loving this.
Yes. Okay. You can have a seat. And I also want you to imagine that you have something, a twin, that can do everything exactly the same way. And that's Lisa right there. So Lisa was born with spastic CP, and I guess continued with spastic CP, but has a twin that was unaffected completely. So with that, I'll let Lisa kind of lead her way and introduce yourself, kind of where you came from,
Sure.
where you're going, and then we'll kind of tag team from there.
Some fast backstory. There's a lot of my backstory online, so I'm not going to belabor it. We want to get really practical with the things we're talking about today, because we want to de-escalate some of the fear and anxiety and maybe some of the even pathological disinterest in the neurological aspects of PT and how they affect people like me. I'm 53 years old. As Eric mentioned, I'm a twin. I'm an identical twin. My sister's taller than me. She's not, as Eric said, she's not affected at all. I wouldn't trade being a twin for anything in the world. I think it's part of the reason I was able to be as successful, in the normal people world as I have been, because I had that model. And I had companionship as a kid, which is not something that oftentimes a lot of disabled kids had if they're congenital. Part of the reason I suggested this talk to Eric is that he and I have been kibitzing for about 8 years now about the divide between ortho and neuro, and how a lot of students and young professionals especially will go into the PT profession and they'll be like, I'm just so into outpatient ortho, or I'm just so into treating the athlete, I'm just so into sports, and maybe that's your undergrad degree, sports medicine or something like that. And there's been a lot of hesitancy when I talk about neuro on Twitter. I'm on Twitter a lot about PT issues, with people saying, oh no, neuro is just really scary and it's really complicated and I just don't feel like it's where I fit. And I didn't, having had PT as a kid through my school, which was quote unquote semi-integrated, because I was born in the 60s and mainstreaming was not the thing to do. It was just coming into, I don't even want to say vogue. It was this new radical thing that people were doing, because I was born 10 years before the IDEA law in the US, which says that disabled people need a comparable education. So there was no law in the books when I was born saying that I was required to be educated. Okay? So the idea of having a school with a special ed wing and a normal kid wing and having any interaction between those two wings at all was novel and radical. And I was part of a group of 2 students that were the first people, first kids to be in our school district that were mainstreamed, as they called it then, into a normal school curriculum eventually. Okay, so I got a lot of front-loaded PT, and I remember learning to walk about 3 or 4. So I have memories of that. It's not really clear. And then at about the age of 11, when I quit elementary school, when I finished elementary school, which in my era was 6th grade, I know it's switched now with middle school and all that, it's 5th grade for elementary, I was told at age 11 that I was done with PT. They got me up and walking since about 10. I didn't need any braces or canes for walking, which I did up until that point. And I was basically cut loose with all kinds of kudos and high fives saying, great, you're done, you're wonderful, just go out and live your life. And it was another 35 years before I got any PT at all, because I was told I was done. I was told that nothing more could be done for me, and I was just basically put out to pasture. And I'm part of the 1st or 2nd generation in the country that's lived long enough to think about having a normal lifespan. So now I'm no longer a PEDS case. I'm no longer a developmental case. And I'm seeing a lot of pushback, at least on Twitter, so I can't speak for people off Twitter, of people that are afraid of neuro. And I'm like, but I'm neuro. So that means you're afraid of me. Or I'll have people say to me, oh, I'm not afraid of neuro, I treat everybody. Everybody deserves treatment, blah, blah, blah. But it's just not my thing, I need more training, it's just not a population I'm familiar with. And part of the things that Eric and I learned about from each other is that there's no there in terms of this grand divide. The grand divide is something that's artificially made up. And neurological issues need to be integrated into ortho issues and vice versa. And if you separate the two, you're essentially providing professionally sanctioned segregation. And I personally take that seriously.
Can you say that again? Professionally sanctioned. Say it out loud.
You're sponsoring professionally sanctioned segregation. I was bullied a lot in school, and it hasn't even quite completely stopped as an adult. I still get pushback, not nearly as much as I did as a kid, but you need to get out of this idea that people with neurological disabilities, I have cerebral palsy, but you go Parkinson's, stroke, other things, and help me out here. Multiple sclerosis, things like that. You need to get rid of this idea that those people are so different from the weekend warriors that you treat, from the athletes that you want to treat, because we're not that different. And the main thrust of this talk is going to be showing you guys in very practical ways how they're the same, how they're different, and how you can sort of tweak your treatment philosophy, your goals in treatment based on someone with an ongoing chronic condition, because I'm not somebody you can fix, okay? Which I think is part of what makes people not be attracted to people that are neuro, because we're not 100% fixable. And that doesn't indicate a failure on your part, unless that's a reason you fail to treat or fail to treat enthusiastically. Okay.
How many people are going to graduate here? We're surrounded by a couple of students, by the way. How many people plan on graduating? Jake, keep your hand down, please. Yeah. I hope everyone raises their hand, okay? How many people are going into a clinical setting after they graduate? Okay. Anybody not want to do clinical settings? Okay. So you will be seeing patients at some point, and I want to be very clear that there will be no delineation of who's walking through your door. Anyone ever heard of the silver tsunami? Baby boomers? They're all hitting 65, 70, and the prevalence of neuro conditions is higher than ever. So if you're not equipped or not prepared, you're not only going to be missing the boat, but you're going to be losing patients too.
And money.
And money. Patients are money. Physical therapy is a business, and that's a whole nother talk that we won't get into today. But so being prepared, and that's part of the reason why we wanted to do it, is that especially when I kind of came out of school, and that was about 9 years ago, there was a very hard delineation. And now I would like to try and blur that. And I don't know how school is structured at this point. Do you feel that there's a delineation between ortho and neuro? Okay. Do you feel like if you treat neuro, you treat in one way, if you treat ortho, you treat another way? Can you do joint mobs on a neuro patient? Sure. Do they teach you how to do that?
Not specifically.
Not specifically, right? So those sorts of things are going to be important because, actually, Shannon, can I have you come up here? Yeah. This is going to be fun.
You didn't put this on her cold, did you?
I did. No, I kind of did. This
really?
is bad. But I brought her mug. She gave her a mug.
He did bring my mug.
Can you close your eyes for me? Mm-hmm. Okay. Did you feel that?
Yes.
How did you feel that?
Because I was aware of it.
Aware of it? Were you aware of that?
How was I aware of it? Because,
Take me through the process.
well, my light touch sensation is intact.
Okay. How did that travel? How did you get aware of that?
Words. Because my sensation is intact.
Right.
But
What's the pathway that gets to your brain?
which pathway?
As opposed to blood vessels or muscles or Nerve?
Neurological, you mean?
Yeah, nerve, right?
Yes.
Okay. So would you say you have a nervous system?
Yes.
Lisa, can you close your eyes for me? Did you feel that?
Yes.
Would you say she has a nervous system too?
Yes.
Awesome. You guys are like the same. This is so cool.
We're twins.
We're like the same. You're even matching colors with
You have
that.
another twin.
How many spinal
We're
or
triplets.
how many cranial nerves do you have?
12.
How many people have 12 cranial nerves? Lisa, do you have 12 cranial nerves?
I assume so.
You do. What's number 11? Yeah. You have a spinal accessory too, okay? Everybody operates on the same primitive basis. We all came up the same way. We all deserve to be treated the same way. It's just your expectations of that, and that's part of what we're doing today, okay? Does anybody have questions so far?
Go ahead.
Yeah, this is an open forum.
Anything, please.
She likes to swear too, but she's alive, so she won't.
He thinks.
So far, so good? Awesome. Can you talk a little bit, thank you, Shannon, PTW. I want you to talk a little bit about when you were done with PT when you were like 10 or 11. What was your expectation? What did they tell you was going to happen?
They didn't tell me anything. That was part of the problem. They were just like, "Great, you're up and walking." But when I was in PT as a kid, it was PT was presented to me as maybe your parents said to you, "Eat your vegetables, grow big and strong." So, exercise was good. More exercise was better. And the ... was, if I do more exercises, I get better. And if I do enough exercises, by extension, I must get well. I must be better, completely better, like completely well. And that disconnect was never explained to me. Not as a child and not as an adult. Nobody ever said to me, "What's your understanding of your prognosis?" I asked doctors repeatedly, "Is this going to get worse?" And the consistent answer was, "This is not neurologically progressive." That is not the question that I asked. Answer the questions you are asked. And for those of you considering peds or maybe working with young people, the only thing worse than bad news is bad news late. Okay? I had no expectation that physically I would be 25 years behind the curve. You know, I have the bones of an 80-year-old because of severe osteoporosis. For 14 years, between 10 and 24, I was able to walk without any assistive devices at all. No one ever said to me, "This is going to get better, but then it's going to get worse." So I lost functional time, I lost planning time, and that's very psychologically difficult to have to finally come up. And I didn't learn a lot of this stuff until 45, and later when I started coming to him. Because one of the most important things that Eric ever said to me, and I know I've said this to you, is he said to me one day early on in our relationship, he said, "I can't get your hip flexors better." Which sounds like really bad news. And it was bad news. Like, oh crap, he can't get my hip flexors better. Not that this was particularly surprising to me, just that, you know, you kind of hold on to that hope that, you know. But the important thing that he said after that was, "But I can keep them from getting worse." And that was one of the best days of my life and one of the worst days of my life at the same time. Because while it forced me to deal with issues of aging and that I was going to age faster and harder and have more things to consider earlier in life than most people who age, I also knew he wasn't going to BS me. That I finally had someone that I could talk to who understood that I was tired, that it hurt, and that while he couldn't fix everything, he could fix some things to give me serious quality of life. I work a 40-hour week. I have a freaking mortgage. I've got to work. I can't not work. I've got no children. I've got no nuclear family of my own. You know, when I get old, well, I guess by your standards I would be old, but when I get older than I am now, it's not going to get easier. It's going to get harder. And a lot of our working relationship is just, how do I MacGyver my life to make it so that I can keep my independence and have a quality of life that is meaningful to me. So.
What brought you to me in the first place?
Oh, boring. Low back pain.
Yeah.
Don't they teach that first semester, don't they?
I don't know. Do they these days?
I don't know.
Your
But
first
yeah,
year?
it was low back pain. I've been working at my desk job for I don't know, 15 to 20 years at that point. And I was getting really sore, and just the hip flexors were tight because the back was sore, and I expected I'd need a brace because I didn't understand any of the stuff that was going on with me PT-wise or orthopedically or whatever. And so I came to him for that and was with insurance for about 5 years. Came to him episodically as my back issues became a problem off and on, or I had right hip flexor problems. I'm right side dominant, and my left leg only really kicks in when it has to, and then at about half speed. So I was having a lot of right hammy issues, and so I saw him episodically for 5 years. And about 3 years ago, I decided to go cash because I wanted maintenance PT, and insurance won't pay for that. But I made enough money so that I could afford to do that. So for now, we're good.
So we have a neuro patient coming in for an ortho problem. How many of you have seen that in the clinic? How many have been on clinicals so far? A couple. Okay. Yeah. Clinical life.
It
Clinical
counts.
life, right?
You know?
It's not students anymore.
And
Yes,
so,
you are.
Yeah, student of life, right?
Yeah.
Yeah. So you've got to come in with a mindset of you're going to treat the patient, not necessarily treat the condition, right? You don't know what you're going to get, but do you have tools to treat neuro patients? Do you have tools to treat ortho patients? And can you combine those two into a functional cohesiveness? I think so, and that's kind of why we're trying to be here.
Yeah.
But what brought you in the second time? Do you remember?
The second time?
Or third time, or your shoulder?
Oh, yeah.
Yeah.
I blew my left shoulder out twice in the space of a couple of years, I think. Yeah. Since my legs aren't the most reliable, I rely on my arms. I was, up until recently, I was using 2 canes. And so I was mostly weight bearing on my arms. And if you blow out an arm and you've got no orthopedic issues, it's inconvenient. If you blow out an arm and you have orthopedic issues with your legs, walking becomes a problem. And so that was a big deal. But we beat that back twice, and I haven't had any big issues since.
Would you say maintenance PT is working for you?
Oh my God, yeah. Yeah, I don't know that I'd be working without Eric. Certainly not full time. And that's a very important thing for me, not only financially, but psychologically. Because as soon as you're out of the workforce, you become less of a force in society. You become less integrated. It becomes more segregated. It does. Yeah.
How many are involved? I know Shannon is, like, with any sort of student assembly stuff within the APTA. Anyone else? What do you do?
I'm a part of the AZ Seg like Shannon.
Okay, gotcha.
I'm on 2 committees.
Gotcha. So,
Cool.
You guys as a students have, and us as professionals as well, but definitely as students have an opportunity now. I would imagine your school required you to be APTA members for the time being, to start seeing where the trend in the profession is going. And you probably have heard it before, we're the lowest cost and probably the best bang for your buck. But the reason Lisa went cash, if you're cool with me talking about it, insurances are now putting authorizations. Can Lisa get better in 5 visits? No. Okay. But that's what they want. They want these cut and dry cases where you get 5 visits to do what you want to do. And it's not going to change without the voice of the people. This is kind of going on a soapbox for a little bit. But you are an excellent opportunity to start looking at where this profession is going and take advantage of that and make your voices heard. And, insurances only survive if we pay them. And if you can show that you demonstrate your value and the people abandon that, you'll see a huge change in tide, I guess.
I make a decent buck, plus I get a frequent flyer discount.
Right. That.
Yeah, I don't know what 3 times. Yeah.
Right.
With 3 times your going rate times 52 is, but it's a chunk.
Yeah.
So.
What questions do you guys have so far?
Come on, don't be shy. It's okay. Anything. Anyone?
How far off are we from being able to perform maintenance PT?
That's an excellent question.
Legislatively, like how far are we?
I think it's going to be a battle. I mean, think about the money, let's say, Cigna has to sit in a courtroom and battle something versus that. And I don't think it's going to happen necessarily in a courtroom. I think you're going to see it happen by virtue that people choose not to take that route anymore. And they're going to say, okay, I'd rather do cash like Lisa, or I'm going to abandon ship to another insurance that's willing to do that sort of stuff. Certain insurances are paying for maintenance PT, but you have to, it's a delicate balance, and it's rare, very rare.
And primary reason, well, I mean, there's a lot of reasons I went cash. Part of it was I needed maintenance PT, and part of it was psychological. Part of it was just like, I have no family near me. And I just needed to know that, other than my boss who cared whether I showed up on time, that there was one person on the planet that had an eyeball on me, that cared about what was happening to me. Also, insurance wants you to tackle one problem at a time, and I can have a different problem every week. And I needed to be able to shift gears and to basically run my own show. So that was those are the other two of the other big factors.
How many people have gone through a neuro like treatment class? Like labs and stuff like that, you've gone through it, treatment and tests like that. Let's say, did you learn about cerebral palsy? Okay.
What
Good.
did you learn? Just I'm not trying to put you on the spot. I'm just curious. What did they tell you?
Well, we learned it last year and how things are performed with it and like the types of conditions and what causes it and whatnot. But we haven't learned how to treat it.
Gotcha.
Yeah, any discussion about adults with CP?
We learned that it's a non-progressive neurological disorder that when you have it, you don't need motor milestones.
Uh-huh.
Right.
What happens after you're 5? But that, I mean, I'm not trying to put you on the spot, but I'm just saying that's a rhetorical question. What happens when you're not 5 anymore? You know, my biggest milestone is, I mean, my biggest ADL problem is not brushing my teeth or going to the bathroom or dressing myself. You know, my normal ADL problem is, okay, how do I get the groceries from the car to the kitchen?
That's what we're talking about. Yes, Shane.
Our professor, she did, and I think only because she has experience with her family, she did make note that even though it's non-progressive does not mean that it doesn't change throughout life, which
Yeah.
I appreciated, but I wish that we had more courses dedicated to neuro, because I feel like and this isn't trying to downplay or try and be negative, but I almost wish that we had more rather than a couple lectures, because for me, I almost feel like it's been inadequate, but I feel like there's still more to learn. There's always more to learn.
Oh, yeah.
I just wish that we had more of a foundation, like you're saying. Like we have, how many classes would you say towards ortho?
So much.
But we have one neuro class.
Mhm.
So
Sure.
Yeah. People spend time and money on the things they think are important. People spend time and money on the things they think are important. And that goes for all of you, that goes for everybody that's already in the profession, that goes for PTA students, that goes for professors, that goes for people in related medical fields, stuff like that. If you're not spending money on it and you're not spending time on it, I don't care what you say, you don't care about it. And that has repercussions for the individual. You know, I like to say that there are two kinds of people that you affect in your student and in your professional career. The first is the group of people that you treat. Okay? The second is the group of people that you don't treat. And people kind of look at me sometimes, what does that mean? If I don't treat them, then how can... It's by the very fact that you don't treat them. And I want you to think about that. That's important.
You kind of coming back to you. What was your name? I'm sorry.
Juliet.
Juliet. Nice to meet you.
Thank you, by the way,
Yes,
both of you.
You said you didn't learn how to treat CP. Yeah,
I'm
okay.
sure.
Can we?
Yeah,
Can
we
we?
can.
Can we?
Okay. Have you gone through any ortho courses? Yeah. Okay. Tell me what you learned for low back pain in that.
By the way, I'm gonna have to stand up soon.
Yeah, you can stand. We're gonna.
Can I stand?
The reason we're segueing right now.
All right, so
Yeah.
I'm gonna stand.
You can stand. What did you learn for?
I'm not trying
let's
to make
say
a point, I'm just
generic
trying
low
to
back
unhook.
pain. Let's not get too. But what sort of techniques did you learn?
Like repeated movements, like if they prefer flexion or extension or
Gotcha.
Like a
Classification system with that?
Yeah.
Okay. I'm gonna pick on you, I'm so sorry. Like, this is awesome. Would you mind coming up here? Yeah, this is cool. Jenna, can you be my camera person?
Do you need me to sit down to get out of the way?
I think we'll probably, we'll lay down actually on your stomach.
Me or her?
You.
Oh, okay. Here, take my cheat sheet.
Can you get up there? You need to be dropping down. I'm gonna have to pull it.
Yeah, a little bit down would be great.
I can't see if it's pointing in the right direction.
Yeah, it looks pretty good.
You know what, you could probably double, oh no.
I'm
we'll let
probably gonna be
move.
okay,
Yes,
but I want
can.
you to stand there and just watch me.
There you go, it's switched around.
Yeah, I just don't wanna fling myself over the
Drop it a
edge.
little bit lower than Lisa.
Okay, alright, yeah. I just feel better having you there. Him I don't worry about.
Oh, you're gonna have this thing.
It's been that way for like
8 years. When's our official anniversary?
It's August, right?
It's August something.
Yeah. Have to
We need a
go back.
cake.
I'm gonna drop these down just this week.
Where do you want me?
Right there's fine.
Alright, let me come on.
Was it Julia or Juliet?
Julia, I think.
Okay, perfect. She has a little back.
Yep.
Can we agree on that?
Still there.
Yeah, can you palpate that for me? Tell me what you think.
You can flip up the shirt if you need to.
Okay. Is it okay if I lower this down too?
A little bit.
Okay.
You didn't think you'd be doing this today, did you?
Doing fine.
What do you think as far as just overall impression?
Tell the truth.
Well, there's nothing wrong with her skin. Of course, she's more laterally flexed to her right. I can see that just by feeling muscles, it's a little more tight on her left side than her right.
Can you maybe assess the joint mobility and see what you think as far as lumbar and thoracic joint mobility? Jake, have you ever done this before?
No.
Never. Not even kind of maybe assess what do you think? How does that feel and kind of chat a little
You
bit?
used to work on my paraspinals,
Mm-hmm.
which I still think sounds like an Italian side dish, but
Her lumbar's actually pretty good.
Right.
Yeah.
Okay. What are your thoughts on thoracic spine mobility?
I'd say a little bit less compared to the lumbar.
So, let's sit, in summary, you said paraspinals are a little tight,
Yeah.
then maybe a little right laterally flexed.
Yeah.
Hypermobile, relatively lumbar spine versus a hypomobile thoracic spine. Did they teach you how to manage that in your ortho class?
How to manage it?
Yeah. What would you do for a hypomobile thoracic spine?
Well, that's when you do, that's when you can do the PAs that, like what I was doing.
Perfect.
And then, for direction preference that they prefer, that's when you can do like either flexion exercises or extension, just to elongate the muscles. And then
If she's tight here, what would you do for that?
on the left side,
Or in thoracic or lumbar paraspinals in general, what would you do for that?
hey,
well, you can, then put your supine under the double knee chest just to elongate the,
So manually, what would you do besides that?
and that's when you can do some manual work just to, like what I used to do in clinic was come here and just like
Get the other, yeah.
pretty much get
Drop the
there and
elbow?
just like to like melt away the
So you do
muscle.
some soft tissue work?
Yeah, pretty
Does
much.
it matter if she has cerebral palsy? But I mean, because you're using ortho techniques on a neuro person, and I'm a little scared. No,
I'm
kidding,
completely
messing with you.
terrified.
I was like, why would you
Yeah,
be scared?
yeah, no, like.
I'm completely
As long-
terrified as I fall asleep.
So did you learn how to treat people with cerebral palsy? No? But you did, right?
Well, right
Yeah.
now I did.
Yeah.
Yeah.
It's a trick
Is
question.
it any different than treating a neuro person?
It's a trick
Do you find
question.
a problem with? Find ways to solve it through manual and exercise? Will her exercises maybe be different than someone who doesn't have cerebral palsy?
Well, you adjust it if you find an issue with it, but
So is there any reason to be worried about neuro versus ortho?
I'm not worried right now.
That's good. So, Shannon, come on. Thank you very much.
Cause she can. Shannon used to work on me.
Can we get you laying on your back?
Okay. Shannon used to work on me.
Yes.
She's pretty good. Wait, if you could spot me for a second,
Yep.
that'd be great, because I don't know where the edge is.
You gotta take your glasses.
Yeah. Actually, no, hold on, I'll just put them on my face. Hold on
Can we assess hip flexors? You've done that
a
before.
second. No.
Yes, we
This is-
can.
Okay.
This is the stuff that scares everybody when they first meet me. It's like, oh my god, the hip flexors. I'm like, yeah, I know.
And just, again, same thing like we did. What do you feel? What's tight? What's not tight?
Mind if I go ahead and
Yeah.
look around through here?
No, go ahead. Do you want my leg straight or no? It doesn't
Can.
matter. Doesn't matter. Well, as straight as it gets, yeah.
Any issues there?
Not at the moment. You trying for it?
No, just making sure. Okay.
Okay.
This side feels a little bit more fun.
Okay. Tissue's tight?
Mm-hmm.
What would you do for that?
Some soft tissue mobilizations or hang out there a little bit.
Which class did you learn that in?
A lot of ortho ones.
A lot of ortho classes,
Mhm.
right? Did you learn how to treat a CP patient?
Yes, we did.
Yes, you did. What else could you do for that tension?
We could do some stretches. With that, just try and lengthen it. We could do
So stretches. Did you learn any neuro stretches?
not specified neuro. No,
What sort of neuro techniques, like repatterning techniques, would you say you learned?
we did some D1, D2 patterns.
Patterns?
Mhm.
Okay,
PNF is great.
great.
Love PNF.
So, do you think maybe like a PNF or like a contract relax might work for you?
Yes.
Can we try that?
Yes.
Are you okay if you try
Yeah,
that?
sure.
Let's get you laying on your side facing me.
Oh, okay. Hold on. Knees bent or no?
Slightly. And can we do a contract relax on that, see if we get any changes in that?
Yes, we can.
Perfect.
I'm gonna try to relax for you. I don't know how well
You
it'll
wanna bring
work.
the table up?
Yeah. Thank you. My device
This
is
is so much
fine.
fun. We gotta do this every week.
I know.
I'm gonna go ahead and just swing my
Yeah, no,
arm.
go, do it, do it.
Alright. Just let
That's
me
one
know.
of the things I like to talk about too when I talk to students is that anybody who's chronic, doesn't have to be somebody with CP, anybody who's chronic is used to being handled.
Actually, can we go down? Thank you.
Don't be afraid to handle us.
So I want you to go ahead and try and bring your knee towards Eric like you're gonna knee him in the gut. I'm gonna give you some resistance. We're gonna hold for 5
Right.
seconds.
Mhm.
5, 4, 3, 2, 1. Go ahead and relax my arm.
Mhm.
I'm just gonna bring your leg towards me.
Mm-hmm. I know what you're doing.
Did you get a little more range out of that?
Yes.
Okay. Can we do that again maybe?
Mm-hmm.
And
Alright.
then give me some estimates on how much you gained.
Okay. Let's go ahead and knee Eric again. 5, 4, 3, 2, 1. Okay.
That was big.
I got to neutral right there.
Okay.
Yeah.
So contract relax work on it.
Mm-hmm.
Okay. Did you learn that in a neuro course?
No.
No. You learned it in an ortho course?
Yes.
Okay. Perfect.
Give
So
me a leg
contract
back.
relax works on a neuro patient, which is weird. Like, so,
Crazy.
I'm
I don't know
happy-
why that's weird, but we'll have that discussion.
I just like to use the word weird. It sounds more
Okay.
professional.
Mm.
Can I have you saddle off to this, and we're gonna pick on Shannon for a second?
Okay. Oh, so you want me up?
Yeah, we'll grab a seat for just a second.
Okay.
Does anyone else know how to do contract relax stretching? Gary? Jake, do you know how? Can I borrow you for a second? Can I get, yeah.
Yeah.
This is Jake. He's a PT. Second Amendment's his favorite.
This is the largest audience we've had for this joke so far.
Can we
And
assess
neuro
her
is his
hip
favorite
flexor?
thing. He
Yeah.
told me.
Can we assess her hip flexor length and maybe do a contract relax on if she needs it? I don't know if she will. Yeah.
You need me to move back? I'm kind of good. Well,
Oh, Shannon. I feel like we've done this before.
Maybe a time or
I
two.
forget how ticklish you are. Let's find out real quick. I think it's probably a safe assumption. You sit all day, you probably got tight hip flexors, right? Perks of being a student. But it's on your side. Listen to your chest. Let's be smart about this. Do your best to stay relaxed. Oh, there's us right there. Take this knee to your chest. All the way. Hold on to it. You feel a stretch right there?
Yep.
You're doing your best to pull up towards your chest. Hold that for 5, 4, 3, 2, 1, and relax. And again, pull up. 5, 4, 3, 2, 1, and relax. Good God, Shane. And again, pull up. 5, 4, 3, 2, 1, and relax. So pretty good stretch there.
Mm-hmm.
Yeah, sure.
Did you say you make a change?
Well, I don't say that.
Just room for improvement. Would you say that contractor relax stretching worked on the non-neuro patient?
Yes.
Yes. I did that on purpose. Thank you.
Thank you, Shannon.
So, I guess what I'm trying to hammer home is that you guys did learn how to treat neuro patients, but they didn't put it in that framework. So, I should say, what questions do you guys have for Lisa, or are you okay if they get their hands on you and just kind of
Sure.
hit and
One at a time, please.
Yeah.
I don't want to be too popular.
It gets a little weird. What questions do you guys have in terms of that?
Yeah, you guys have to have questions. I mean, come on.
Yeah.
We're all adults here.
I was kind of curious what specific problems you were kind of dealing with that you felt were preventing you from kind of possibly working your 40-hour work week that you're coming to me and speaking for.
Currently,
Yeah.
well, part of that is company related. I work mostly from home. When the downturn happened with the economy, our company decided that they could save more money if they sent I'm a customer service rep for a shipping company, and they decided they could save more money by sending the customer service department home and give us a dedicated phone line, a dedicated computer line, and work from home. But now that means even more so that I sit all the time, and I'm tethered to a headset, and I am not allowed to have a cordless headset. Even though I've demonstrated need for it, I've gone to human resources several times, and I went to my vice president several times, and I was told no. Various reasons were given for that. One was we don't want you away from your desk because your job is email dependent. Even though there's a lot of phones involved, it's mostly email dependent. And the other reason I was given is that they were afraid I was going to fall. I'm like, well, at some point I have to get up to go to the bathroom. So, I don't understand what that is there. So what I did is a couple things. Mostly with regard to the job, I got myself an electric standing desk, which set me back over $500. The company was making noises like they were going to pay for it, but I didn't want them to pay for it and then say to me 6 months down the line, well, we got you a standing desk, why you're asking for something else. And this is a company that, until this point, has been largely supportive of my condition and my need for some limited accommodations. So there's that. Did I answer the question?
I think he's wanting to know, like, why are we treating you in terms of like condition, like
I'm sorry.
hamstring? Am I in that regard? And then
Okay.
like,
Yeah, my hammy, I'm right side dominant, like I mentioned. My right hammy does most of the work, and it is overloaded. It is really tired. It's cranky most of the time. And if I lose that leg, appreciably, I lose the ability to walk. The only time my left leg managed to really kick in any significant way was when I had a car accident about 10 years ago when I broke my right hip because a Toyota landed on it. And so for that short period of recovery, my left leg had to kick in. It was either that or not walk at all. So there's right hammy issues. There's still low back pain issues, although it's improved by about 90%. Because what I was doing before I came to Eric, I would sit all day at home working, and then I'd think, okay, well, I'm going to stretch my back and I'm going to curl up in a ball, and that's going to stretch my back and I'll feel better. And it was, of course, the absolute wrong thing to do because that just exacerbated what I was going through. So So it's largely hammy and low back. My balance has become appreciably worse with time. My strength is still there. My stamina is not all that good, but my strength is still there. So we've been doing some weight training, a lot of balance training. Jake taught me how to use a subway while not being on a subway. I'm originally from Philadelphia, so that was a big deal. And I left Philadelphia because the walking got to be too much, because I was too tired. I left at 29. And I visited there a year ago, and Jake was the one I worked with for 2 months while he was a student here, and he basically spent a lot of time trying to knock me over. And that was fun, because I went to Philadelphia and had a complete blast. And just to see the old home and be able to ride the trains and not fall, and that was just great. And I'm going to do it again in another couple months, and that's a lot of fun. So that's a quality of life thing for me in a big way.
Can you tell them what your home program looks like?
Right now, I bought myself a weight vest because Eric and I do some kettlebell work in clinic. I have a small kettlebell where I do some chest presses and stuff like that when I'm on the floor, but I don't tend to use the kettlebells. I don't use them at all freestanding, because that would be very dangerous for me. So either I use them holding onto my kitchen table with one hand and then that with the kettlebell, or I use the weight vest, which by the way was my idea, not Eric's. And so was the standing desk, because I got really pissed off. I'm like, I gotta move. I can't think of how not to move. And he kept telling me to walk around. I'm like, they won't let me walk around. So I use a lot of the weight vests. I started out pretty low, like maybe 6 or 7 pounds. And then I got up to, I think my high was 29. But after a week or two of that, my right hammy was not happy. It was too much. So he told me to back off. So I'm now at about 16 pounds. Most days I do six sets of 20. Sit to stands. I can't do a proper squat, but that's okay with me. I still get it done. Eric's brought up to me very recently that he wants me to start working on some cardio. We have to start talking about that and what's the safe way for me to do cardio, because eventually I'm not going to be able to walk very much at all. Not that I'm very ambulatory now. The rollator is a fairly recent addition. I've had it for about 3 years, but it's only been like the last 3 months where I've used it outside, because I was afraid to lift it. I don't have a ramp at my 1983 condo, and it was either build a very expensive ramp or figure out a way to use get the rollator off the curbs, because there were several, and there are several. And part of I guess part of your idea with the weight training was getting me to the point where I could lift that 14-pound rollator, get it in the back seat of my car, and get it out again. And so I had to switch from the 2 canes to the rollator, because I was getting increasingly wobbly on the 2 canes. I'm battling. Does that answer your question?
Mine?
Yeah.
Yeah, that's
Okay.
covered everything.
Okay, good. I get off on tangents. I told him he has to rein me in when I start to rant.
Yeah.
It's true.
So I think, Lisa, you nailed it on the head earlier when you mentioned that it's a hard pill for us to swallow. There's just things that we won't fix.
Right.
As a clinician, what brought you to conclude or say to Lisa that we can't fix your hip flexors, but this is what we
I
can
loved
do?
him and I hated him that day, but I mostly loved him. I mean, I went home and cried, But it was a good cry.
Just how are you able, what, was it just through trial and error that you said this isn't going to change, or was?
Well, I think part of it was knowing disease process or lack of process, right? And then age and understanding that there's going to be limitations with everything you're going to do, right? And I think you've been in this clinic, you understand that I'm big on expectations. And I think part of Lisa's kind of failure to understand what was going on is because expectations were not set properly when she was a child. She thought she was going to get better if she exercised, and that's not necessarily the case. And I think that by establishing expectations early, you not only show your vulnerable side, which patients really like, but it also says, hey, I'm going to do the best I can, but here's a hard line. There's going to be a point to where this isn't going to get any more flexible, but can we learn how to manage it? You got to sandwich the bad news with some good stuff, but if you're, misleading, whether that's directly or indirectly, you're destroying that trust one way or the other. And you know, if I told you that there's coffee out on the front, which there is, it's good, and there was no coffee, it wouldn't be small, but it would be a micro fracture of that trust. And enough of those will break that trust entirely. Whereas, you know, if I said, hey, there's coffee up here, there's going to be some seats in the back, and there are folded seats back there, feel free to grab one. I've already, you know, told you a truth, and so now we're establishing micro truths, and you're going to develop a much stronger bond. And I think Lisa knows now that I'll tell her what I really think, because it's not my life to live. You know, I want to set expectations. And I think one of the hardest conversations that we've had to date was the rollator conversation.
Yeah, that was really hard.
And having her acknowledge that at some point she's not going to use her canes. She's going to need to use a rollator full time. And I think that was, at least from my interpretation, a very hard pill to swallow.
Yes.
And
Yeah.
you left pretty angry that day. And I think that it took probably the better part of a year for, I think, you to come to terms
Yeah.
in that regard.
Because he was starting that conversation, seeding that conversation, for lack of a better way of putting it, for a year, I don't know, a year or two. And finally I said, okay, you know, I can't walk across my living room anymore. And I don't have a particularly big living room. And it wasn't just like I'm walking badly. I can't do it at all. So all my household chores became one-handed. I walked around the edges of rooms. And I'm like, well, this isn't any way to live. So he and I sort of compromised. I said, okay, fine, I'll use it inside. But I can't get it out of my condo, and I really don't want to be seen using a rollator. I've had a lot of hardware in my life, and except for a span of 14 years, from 10 to 24, it's always included some type of hardware. And it's not sexy, it's not socially acceptable. It puts a barrier between you and the general population. So I was not eager to be seen as somebody who needed a rollator at 50 at the time. Now, I wasn't a little old lady. And I didn't like that portended, oh, a few more years and I'll be in a wheelchair, and then what the heck did I do then? You know, because it's a different world when you sit down. Not that you can't have quality of life, but it's a different quality of life. You know, and I wasn't ready for that. So we kind of compromised, and so I got to see how I was so tired before using the rollator. I mean, I was just exhausted. And I'd come in every session and I'd be like, I'm just so freaking tired. And he'd be like, yeah? And I'd be like, no, I can't. Yeah, okay. All right, so I'll use it inside. And then chores became easy. I never spilled my drink, you know? I could roll, you know, dinner from the kitchen to the living room while I watched Jeopardy or whatever, you know? So it became really value added inside. And then once we started the strength training, and it was about 3 months ago, was it 3 months ago, maybe 2? I don't know, it hasn't been long. I haven't been using it outside long. But I mean, one of the podcasts I did with the Ducklets podcast, I was talking with some other students about how scary it was my first time outside with a rollator. And I'm at sidewalk level, and you saw how high that curve is, and you probably didn't think about it, but it's really high as curves go. And he's down at parking lot level, and I'm there holding on for dear life with my rollator, and he's in front of me, just physically doing this, so I would feel safe. And I just stood there and I cried, because it felt exactly like when I was 7, and my school PT took me out in the middle of the clinic and said, okay, I'm gonna let go of your hands now, and you're gonna stand by yourself. And that's what that felt like. All of that emotion kept rolling back, and I'm like, you know, and at that point, I'm an adult, and I know if I can't conquer this curve, I can't live alone. I can't continue working. I can't do 50 things that I want to do. If I can't do this, everything changes. And to his credit, you just kept cool. Just like, why are you crying? What's up? You know, he wasn't berating me. He was just kind of like, where are you at in your head? I'm like, well, this is where I'm at. I just did it badly a few times. I never fell. Always, you know, it's like, okay, so this is just a matter of brakes on, brakes off, brakes on. Okay, so I just got to time the braking right, and I'm fine. You know, so that's my new party trick, I guess. But it takes years, and some people are like, oh, well, they didn't listen to me. They're not compliant. Yeah, well, you know, you're a bunch of jocks in the gym class that did really well at sports and everything else, and then you have to deal with a bunch of people who are exactly not that, and then you wonder why they don't comply. Because you can't convince me that exercise is the greatest thing ever until you connect it with something that's important to me. And that is not an exercise or sports or activity independent of itself. You can't make me the best you. You only have to make me the best me. It's not the best you. You make me the best me with the raw material that you have. And that's all. That's all I want. Because if you're trying to make mini-me's, you're going to make a lot of enemies. You know?
I think, you know, you put the value in and people will begin to trust you.
Right.
You know, but if you don't show them the value and you don't speak their language, they're not going to trust you.
Right.
And so I think at PT too that, you know, we've gotten into a framework that this is an episodic care. You see somebody for 12 visits and they go along their merry way. You're creating plans of care for 12 weeks. How about 50 years? And that's the kind of framework that we've got to start thinking about, especially as folks come up and we've got a large amount of the population aging, is that this is not just for this 4-week period. You'll have patients that'll do that, but this is a lifetime. And how are you going to prep them for the rest of their life? Man, I got heavy.
Dun, 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 dun.
Yeah, wow. What other questions you guys have?
Yeah, please, ask. And I'm sorry if I go off on tangents, you can bring me back. Throw something soft. Shoe, whatever.
Where do you feel like there is a area for the neuro to stay neuro segregated from orthopedics if most of the techniques transfer into neuro also?
Right, I think it depends on what are your goals. Certainly not every neuro patient is going to be able to ambulate into my clinic. You're going to need some extra equipment for that. There are neuro specialty clinics for that. So I think it would depend on the ability of the patient, but will that patient respond to a manual touch the way an orthopedic patient would? Absolutely. So, you know, it's the capacity to which you can treat them safely and effectively. So, you know, it might be that you need a Hoyer lift to get them out of bed. That's not my show here.
Right.
You know, but if you can walk in, I guarantee that I can show you something that'll make your life better and you can walk out a little bit better. You know?
When I first started here, I had 2 canes, and every once in a while, it had only been a short time that I had the 2 canes. Every once in a while, I'd walk out with 1 cane. One time I had to drive back here to get the other cane. Okay, so that's where I am at now. I don't walk across the room unassisted. I can't get off the floor unassisted anymore. But, you know, we worked around it.
Yeah.
It's, you know, it's our normal. You know, this is our normal. And sometimes your normal is boring. Describe it. Does that make any sense? Help me out here. Come on, you guys. Come on, let's hear from the experienced folk.
Alright, how do you vacuum? Do you have a Roomba?
Yes.
She just got
I had the original version about 15 years ago, and then it wouldn't hold a charge. And then I was able to, that was just kind of a novel thing. I would still be able to vacuum. And then a few years ago, I stopped completely. I just got the carpet shampooed more often. So I just lived with dirt, basically. You know, everything else was neat and tidy, but the floor was crap. And then the new Roombas came out, and I'm like, okay, I'm going to do this again. So I absolutely love it. And I've gone semi-minimalist. I know that's a big thing, tiny house movement, all that. It's like, when you don't have to pull up a bunch off the floor so that your Roomba can do its job, it's just fabulous. It's just great. But, you know, it was also $300. So that's cost prohibitive for a lot of people. I found my vacuum a good home. My neighbor upstairs took it. Anything else from you guys? Val?
Yeah. So I've made a great friend over the last 6 to 8 weeks. He's being treated for ortho, CP patient. My age, so our sense of humor just clicked. And one of the things that I'm glad that you mentioned, and I was not a fan of in school, trying to get that rhythm of the PNF patterns and all, but this patient being young, he's active. His car costs 3 of mine. He drives independently. He's a very independent person. He plays poker. He does not want to be treated anything that, unlike what I would want to be treated. But technically, when it came down to it, he had a cleanup in his shoulder. He was an ortho patient. So first visit that I got him, I'm a PTA, so I don't do your fun paperwork. But I want you to keep in mind, you guys gotta kind of break out of the norm of the PT, looking at the numbers and the ADL stuff, and actually ask what people like to do. Because the second visit in, he said, I've been a PT my entire life. There's nothing that you can tell me to do that I haven't already done before. And that really, really went home with me. And being that we're the same age, I thought this would be like if I had a twin like that. Like we just clicked. And he likes to go out shooting with his friends, and he you know, we've seen some of these cases are a little more difficult than others, and for him to independently load his own magazine on his gun, or to be able to drive with his arm that is technically his surgical arm, and knowing that one arm is our fine motor and one is our gross motor control, you have to be able to adapt. And so we changed up his exercise plan and said, oh, you need to be able to stand like this. They'll show me how you would stand at the range. Oh, okay, here we go. He's got bad knees. You know, he does not use a device at this time. He's trying to prolong that as long as he possibly can.
I so relate to that.
Yeah.
It's just like, oh, please God, no more hardware.
Yeah,
I just can't
and
take
he
it
said there's
anymore.
nothing that they can give me that's going to work for me because my knee is not like your knee. So we worked on a lot of stability and standing in a certain pattern so he could take that dive back into things, being a shoulder patient. And then talking about baby boomers, you know, what did you call that? Silver tsunami?
The silver tsunami,
I
yeah.
love this. Okay, so I'm taking that away from here. 73, I think she is. Lives fairly independently. Up to the time we started treating her about 4 weeks ago, never used a cane. She's dealing with foot drop. And no stroke, no nothing. Maybe something happened that didn't show up on the radar. But she's got foot drop issues. And the first few visits, we talked about getting an AFO in the time being, just to work on the strengthening and balance issues. And technically, she's low back pain. But we know that that's gonna be a fall risk problem. So we convinced her, hey, you know what? It's not gonna be for the long term. Let's work on this. You do have some of that function. We can work on this. We can do this. She bought it, but hasn't bought a shoe to go with it. She likes to wear sandals. Had a fall, getting out of bed to use the restroom in the middle of the night. Came in, we checked her, no fracture, no nothing. Said, look, I really think you'd be safe using a cane at least a cane. She had tears in her eyes.
Mhm.
She came into the clinic yesterday. It took everything she had not to cry in front of me because she had another fall. She doesn't know why she had a fall. And I sent her home yesterday. I taught her how. I went out to the parking lot. You have to be able to go out of the clinic. You have to be able to not just be textbook when you treat. We went outside. We learned how to use a walker that's one of ours from the clinic. I gave it to her yesterday to use in the meantime because she had to come to those facts that she needs a walker at this point. There's something going on, and because we're outpatient ortho, we're not neuro specialty in our clinic. I don't know exactly what's going on with her right now, but we have to treat what we can and make her safe so she'll stop falling. And thankfully, no hip fracture, but you know it was a tough call yesterday, having to take her out and say, okay, now what? And I've been watching her for a couple weeks, and despite me telling her everything under the sun, telling her this isn't safe to do, I'm watching her put her palm on a hot car because that's her stability right now.
Oh, I have a suggestion for that. Hot cars, meal works, bicycle gloves.
This is why we listen to Lisa.
I have them with me. They're in my wallet.
Your number one thing is going to be advocacy. I'm going to tell you that right now. You have to be dive into your notes and say exactly why. It might not be that the grocery thing. It might be something else, that something at home is keeping them and they're a fall risk from that. Make your notes as detailed as possible when you deal with these insurance companies that you ask for 8 visits and they give you 2. That happened last week. You work 2 and you have to send off more authorization and beg and plead for your case, but if your notes are shoddy, you're not going to get your visits. Your patient's going to be declared not fit for PT. They can do a home program, send them all the information home and hope that nothing bad happens. So documentation and advocacy. You are on team patient always. That's why we went into this field. We didn't go into this field to do anything other than help and fix people, right? Sure wasn't for the money when we want to talk about debt, right? So if you're not on Twitter, I greatly encourage you to be on Twitter. Follow Lisa because she is a huge patient advocate. There's lots more like her out there. Maybe not as vocal. I wish they were.
It's a gift.
Yeah, it's all right.
She's in several podcasts too, if you guys are podcast listeners. Very, very good. I'm opening up a Facebook group as far as mentorship. If you guys are interested and want to get involved in that, you certainly can throw your email down. I'll email you the link to it if you guys want to do that. Some people like what I have to say, some people don't. My students have to listen, so it's awesome.
I know. I know the feeling.
Yeah.
You're trapped too. You have to listen to me.
Yeah. So if you're interested in that, I'd be happy to kind of provide a forum for that and kind of keep the advocacy alive, and I'll put the links and everything in that as well. Does anyone else have any questions? I'd say that's probably the sum total of the regular information, but if you guys have questions, whether it's related to this or not,
Yeah.
I'm opening it up to it.
You guys need to, come on. I've heard it all.
You know, join the wave and making sure we push to have patients at our student, not only the student, but the APTA functions.
Right.
Lisa went to one in fairly recent years. I
2016.
actually met Lisa at it was the PT student SIG. She came in to speak with Jerry Durham.
Right, okay.
You were using the two canes at that time, so
Yeah.
that's how I met her. And if anybody has not been to the NAU Biomedical Campus, it's a long step and then a drop, and then a long step and then a drop. So that was actually my first encounter. Was like, oh, let's see how this goes. She did it fantastically, of course.
Yeah, as I recall, Jerry stopped me and he said to me, he says, you know, everybody's looking at you and they don't know what to do.
Yeah. And yeah, so I met her there. Are you on the student board? Are you on the?
I'm not on the student board.
You are SIG.
Yes, I am.
Okay.
I'm a committee member for the social and service learning.
Awesome. So if you don't know who I am Valerie Bushline I'm the PTA director of professional growth with the early professional SIG. So you all have a home with me when you graduate, or become a third year. But please do follow the SIGs, follow all the SIGs, and follow the student board of director assembly, the student assembly, anything with the APTA, because they're huge on patient advocacy. Our summer of move that everybody likes to do, the hashtag summer of move, and show off what all we're doing. We need to be getting our patients involved.
I was in on that.
Yep, she was. I was following. I was like, woo, go Lisa!
Honestly, I'm feeling a little bit blue about it. I mean, it went okay for a while, and then towards the end, I was just kind of like, I only got I got 1.77. And it was like days of that. And I'm like, some people are bragging about doing 16 points, and I'm like, I'm a freaking failure.
No.
So I don't know. I don't know how brave I'll feel next time, but I suppose somebody else snagged me for it.
You were doing more than some.
All those squats.
Yeah,
Yeah.
the
Push-ups?
squats.
Are you kidding?
Well, I mean, they're modified. I'm still holding on a little bit.
Doesn't matter.
I
Doing
think
something.
you were doing it. I mean, I'm looking at that thinking, oh my gosh, she's like putting us all to shame.
Yeah.
I didn't do it, Lisa, so that makes you feel any better.
Yeah. I'm gonna test out with you there.
You're lifting toddlers.
Yeah.
Yeah.
I was curious to see how your Uber adventure went.
Oh yeah, I was debating. I have a 13-year-old car with 69,000 miles on it. So it's an old car, but since I don't commute for work, since I work from home, I was trying to decide whether Uber or Lyft would work if I needed to buy a new car or not. And turns out Uber and Lyft are a lot more expensive, you know.
Really?
Yeah. So once I pay off my mortgage, I'm gonna start saving for a car. And even if I decide that I don't want to drive, at that point, I'll do a home repair or something else. I'll use it for something.
Yeah.
Buy myself a vacation. I do, in addition to working full time, I do drive a regular automatic car. I'd be hopeless on a stick shift, but that I've had to curb. I don't drive on the highway anymore, and I don't drive at night unless it's absolutely somebody I know, somewhere where I know that I'm going. I have what my eye doctor calls eye teaming difficulty. I have almost no depth perception at all, and that's pretty indicative, or like a bonus of having CP. That's a frequent complication of that. So I drive during the day, off hours as much as I can.
Secondary question: did you feel they were open to like when somebody, because these are regular people jobs of driving people around? Did you feel, and you never know what vehicle you might get, but did you feel that they were open to helping or getting the roll leader in and whatnot?
Well, I can do that, but although there was no pushback with regard to my disability or the hardware, which was great. I mean, I said, okay, finally, if it gets to that point, if I absolutely need to do it, say when I'm retired and I'm, not driving or needing to drive as much, I can still do it and not feel like people are gonna have a freak out on me. But I have talked to drivers who said that there are some drivers who do have a problem with that. They're like nervous about having to, I guess the liability and there's the social comfort factor of dealing with somebody who's disabled, because they think we're from Mars, and we're not.
Really?
Yeah. Anything? Anybody else?
Well, I just want to comment. I think there's a difference between the perspectives of treating like a neuro or an ortho patient, because the way they teach us in school, I mean, at least for our program, that there's a big difference in the assessment between a neuro
How so?
and ortho.
You tell me, because I don't know.
Oh, so like, I guess when we first started our neuro class, they were like, we're doing dermatome testing, like sensation testing, and they're like, I know you learned this in ortho a different way, but this is how you do it for neuro. So I think that's the way people, like students, get scared of like training in neuro, because it's so much different than the ortho that they keep hammering into our heads. So.
Right. Well, I respond to that like Jake's favorite line: "Doesn't matter as long as you test it."
Yeah.
Right.
And my less than polite answer to that is bite me. I don't care.
Just do it already.
Yeah, just do it.
Yeah.
Get over it.
And-
you know, it's a hurdle. You know, you're gonna have things that you're good at, and you're gonna have things that you're not good at. And people's quality of life depends on your willingness to get outside your comfort zone. It's not just about what you're comfortable with. You can't do that. And if I run into a student like that, I'm gonna slap him down real fast. And Shannon knows I don't do that, because I'm a hopeless softie. But yeah, I've made a few less than friends. Let's say frenemies on Twitter for some of the stands that I've taken. Yeah, I just swat it back down. Whatever.
I think,
Okay.
with academia, like, you have to have structure because you have to test something. You have to test your knowledge. But when it comes to application, that's why you go on clinical rotations. But if you can start getting into that framework now, because you're early into it, I think you'll be much better on the way out.
Yeah, I'm 1 in 300 people in the U.S. are born with CP. Medicine's got a lot better. They're great at saving the babies and the cute kids that you can have telethons for. But nobody wants to look at you when you're 30 or 40 or 50. Nobody even thinks you exist if you're 60. Like, I want a life too. I deserve a life. I'm going to get a life, and if I don't get a life, I'm going to be loud about it. We're relying on you guys. I already found a good PT, but I don't want the next person that needs PT that's not cute anymore to have to wait for 35 years till somebody takes them seriously. Because my outcome would have been a whole lot different. I don't think I'd be working now. I think I'd be on disability. And even with Eric, after 8 years of being with Eric, I think I will probably be on disability even within another 5 years or so. Simply because it'll just get too tiring. But I still want a quality of life because I can't work 40 hours a week. Get rid of this idea that we're so different. Yeah.
Have you ever been to an outpatient neuro clinic? Like,
No.
You've never been?
I've never seen an I've never seen a neuro PT. Oh, and that's part of the thing that I wanted to touch on real quick is there's a fascination, not only just ortho over neuro in a lot of cases, there's a fascination with the idea of specialty. Like I'm part of this CSM section, or that group over there, or I'm the shoulder PT, or I'm the knee PT, or I'm the running PT, or whatever else. Give me a good generalist any day. This is the guy I need. He is not a neuro PT. If you dangled the world's best neuro PT in front of me, I'm like, no, I'm Eric's now. We're family, we belong together, we're invested. I didn't walk into his clinic expecting my life to be changed, and it was. And not even for the most part, for what I can do physically now. I mean, like, I've decreased in terms of function appreciably since I started with him. But my ability to cope with my environment has gone up dramatically. So, don't fuck with me when we're talking about. Don't do it. Don't fuck with me about how it's. Well, I've got to feel like I've got to get a patient back to 100%. Okay. Thanks for putting. If I'm your patient, thanks for putting that trip on me. There's a lot of people that segregate me, literally in school when I was young, and then socially, because I don't live up to some predetermined baseline standard. And the last thing I need to hear is somebody in a profession that's supposed to care, that's supposed to understand what I'm going through, is saying a polite version of, we don't want you there, you people are over there, we're over here. Carrots don't touch peas. Well, here comes a pea. You know, deal with it. You know, you're over 18, you're adults. I don't care if you have a pile of debt and you're a student and you're still learning. You're gonna be learning throughout your whole life. Take on adult responsibilities now. Take on mature adult relationships with the people that you work with now. Okay? This whole divide with soft skills versus hard technical skills, manual skills, whatever. That's just so freaking stupid. You're gonna need psych and social at every point in your life, whether you're in the clinic or outside of it. Get used to using it now. You know, I don't know if there's classes that say, oh, psych for PT or psych for oddball populations and stuff like that, okay? But it's just part of being an adult. It's not anything that's specific to PT. You know what I'm saying? I'm just battling here a little bit. Can you expound on that a little bit?
I just think that, you know, get ready to get in the patient's head and understand what they want. Ask them what they want.
Yeah.
Not too hard. Yeah.
Ask us what our definition of success is. There's nothing worse than having somebody else impose their definition of success on you to feed their own ego. Okay? Gotta stop that. That's for kids. You know, it's the big leagues now, whether you're in school or out of it.
I'll add on that. The ask starts, and then you stop and you listen.
Yeah.
Let them have it. Let them tell you. That's where your most successful days are going to be, is actually listening to what your patient wants. It's not about our plan, it's their plan. Every single one is different.
I won't go into detail, but Eric and I had a come to Jesus moment. One time he was trying to get me to do an exercise I just did not feel equal to. And I told him, shut up, and I meant it. I was done. I was so freaking done. And that was what, I don't know, 5 years ago?
Yeah.
And we lived through it. You know, people have fights. Friends have fights.
Emotionally scarred.
Yeah. He still cries at night. Sends me pleading texts. But yeah, you survived it, you know. And any bump in a relationship, you're gonna survive it if it's worth it enough to you to do so. And so my advice and my encouragement to all of you is to step up your game. As hard as it is now, it's never gonna be easier for you to absorb all the knowledge that you need to start. Remember then, it's only a start.
Good start, the fact that you're here on a Saturday.
Yeah,
So,
yeah, I know.
Thank you
it's
guys for being here for
impressive.
sure.
So,
So if you guys have questions, certainly feel free, you can contact us. So, but if you
Yeah.
guys are interested in getting into that group, let me know, leave your email, I'll get a piece of paper out, and
yeah,
I'll let Lisa's contact information there too.
great.
You guys are on?
One last question.
Yes, ma'am.
Sure.
What are your podcasts?
Oh, I was gonna write these down on a
What are the names
whiteboard or
of them?
something.
Duck Legs,
Duck Legs podcast is the most recent.
Healthcare Education Transformation. No.
That's late, that's earlier. What was the one we did together?
Disrupt.
That was Healthcare Disruption with Jerry Durham.
Yep.
That was episode 19.
I can.
Eric and I did that together. It was the
If
first
you guys
one
want
we
to
did
leave your
together. That was a
email,
lot
it's
of
probably
fun.
easier. I'll just provide all the links because,
Fabulous.
yeah,
Um,
all the links.
Senior Rehab podcast from 2016. Patient Perspectives. Two Nobodies. Culture for Dialogue, that was last April. Yeah. And they're long. But you don't have to listen to them all at once.
Oh, I love podcasts.
Oh, me too. Me too. And you know what? When I do them, I always feel like I'm just freaking rambling, and it's like, oh, this is useless. I'm not being helpful at all. And then I listen to it back. It's like, okay, I guess I sound vaguely coherent. Okay. So yes, thank you all so much for coming. I'm gonna hang out for a little bit and see if anybody wants to talk one-on-one. You seriously, ask me anything. I've heard it all. Really have.
Thank you guys very much.
Yeah.
Thank you.